Hi, thank you for watching Ask the Experts. My name is Mike Wang. I'm a neurosurgeon at the University of Miami.
And I'm Mike Steinmetz. I am a neurosurgeon at the Cleveland Clinic.
So today we were going to spend some time talking about MIS deformity surgery, or minimally invasive deformity surgery. And Mike, you're an expert in this topic. I mean, we're going on about 10 years, a decade now, of seeing these techniques proliferate and be applied all over the world. And maybe you can start by sharing with us some of your thoughts and your journey through this and how you've developed your techniques and where you've kind of been going with this.
Sure. I mean, I think the entry into the MIS world, I think, was early on with tubular decompressions. Starting off with microdiscectomies, and then I think just adding complexity over the last 10 to 15 years with moving into fusions, adding percutaneous screws. And then I think eventually getting into the lateral procedure probably is where we had the biggest change with regards to evolution into deformity. And I think that's where it sort of changed from my end, is when we were able to move from the pure posterior aspect of the spine into the lateral aspect to have a bigger, a greater ability to control the coronal plane and now today the sagittal plane. But there were difficulties early on in that. So I think my evolution started simple with just MIS decompressions and then moving into more complex pathologies. And also during this time, as I developed a greater ability to do deformity surgery open, that was much easier than to take a step back and say, what can we do with our techniques we're doing for trauma, for simple decompressions in the degen spine, and can we apply those in the deformed spine as well?
So you bring up that point, and I think if you talk to open deformity surgeons, there really is a very strong emphasis, maybe now more than ever, on the radiographic outcome of the final result when you finish your surgery and correction. And I'd ask you, like, when you do these MIS deformity surgeries, do you see limitations in the degree of correction you can get in either coronal or sagittal plane?
I think the answer to that is yes. Now, we've obviously evolved more so even in the last 5 years in our techniques and in our ability to control both planes. But I'll tell you, early on, I felt I could get an excellent control or correction in the coronal plane, but obviously, similar to other people, was having a difficult time in the sagittal plane, where we left people less optimally corrected. So the answer is yes, but I think now with the newer techniques, releasing the ALL, cage design is expanded so that we have larger cages, even expandable cages. I think that our ability to control and correct in the coronal sagittal plane is much, much greater. Now, I guess the question would be, can you do equally what you can do open versus MIS? And obviously there are limitations if you're going to do a pure MIS with percutaneous screws versus open, where you can do big facetectomies, posterior column osteotomies and screws. So I would say there probably still is some differences between both techniques, but they're catching up and getting closer and closer to equalize, I think.
So patients come to see you in clinic, right? And they have deformity sometimes, and they present with symptoms, and you have to make a decision, right? You have to decide if you're going to operate on them, you're going to do it in a minimally invasive way or open way or hybrid. How do you, is there a way to decide, who's going to get the minimally invasive surgery, who's going to get the open surgery? Does it matter?
I think it does, and I think it really is impactful from your experience, I guess. Because I think today with techniques, Mike, you've pioneered, we can pretty much do even complex osteotomies in an MIS way, and you've led the charge on that. So you probably can accomplish most deformity surgeries even with MIS techniques. The difference is you face potentially greater challenges, risks. It takes a lot of experience to do that. So I think when I look at a patient, I take into account the deformity itself. Is this a rigid, high magnitude curve where I'm going to need a significant degree of correction? And it may be and maybe that's a patient I'm consider doing an open operation. If somebody has a moderate magnitude curve that I think that I don't have to perform significant degrees of osteotomies, perhaps with larger cages if I put in laterally, and then I can correct and maintain it with screws in the back, either open or MIS. That's the patient for me. And also take into account the patient's ages and desires. A lot of them come see us, you and myself, looking for a minimally invasive strategy. And I think we just have to be honest with them in a sense that there are certain scoliotic patients or deformity patients that maybe this is not appropriate for. A high magnitude curve, fixed rigid kyphosis, double major curves, it can be much more challenging to do this MIS. But your standard degenerative, middle magnitude, curve is probably, appropriately treated minimally invasive.
Yeah, that, it's fascinating. And I think that when you talk to most folks, they almost think of this as being synonymous, as you said, to the advancements of lateral surgery, right? And that's obviously been one of the big players in this. And people start to talk about all these corridors, whether it be pre-psoas, anterior to psoas, ATP, O-lift type approaches versus direct lateral through the psoas, shallow docking. I mean, it's all these ways of sort of managing that muscle and all the attendant nerve tissue, right? Do you think this is going to congeal somewhere, or you think it's just going to be like 18 different ways to get through the lateral space? Like, what do you think is going to happen?
So my guess is we'll probably end up in all techniques in either a pre-psoas or an anterior psoas technique. I think even diehard true transpsoas lateral surgeons are moving much more anterior in the psoas now. So I think we may not be purely anterior to psoas or pre-psoas because depending on your hands, oftentimes you need navigation to do that appropriately, and that's how it's used frequently. So that provides limitations to be able to apply this widely across every center in the U.S. But I think what I've seen trend-wise is that people are either going all the way in front of the psoas with navigation or coming anterior, not anterior, but in the anterior aspect of the psoas. I think everything's evolving there, and that's probably where we'll end up. You can use, it's kind of a nice match between both techniques. It gets us safer in the anterior part, but you maybe don't need navigation for that. So that's.
I'm sorry. Do you think that's more because when you think about the reasons that go that way? Nerve protection, less psoas trauma, access to the lower areas L5S1, release ALL. What do you think is really going to drive it? Like is it risk avoidance or is it ability to get to certain sites of the spine?
Well, I think it's both. I think initially, and what makes the most sense is probably risk avoidance, right? The risk of limiting your damage to the lumbosacral plexus, genitofemoral nerve, the psoas, which is huge, but now with the ability to release ALL, get down to L5S1, I think that's what's going to drive it in the future. And so I think that both of them together, I think, are what driving us in front of the psoas, or more of an anterior to psoas technique. But I think both are equally important. It probably started with the risk, and now it's getting into what can I do in that anterior aspect of the spine. Well,
let me wrap up by asking you, put your thinking cap on about the future and project for us. What's going to happen with MIS deformity surgery? Is this like a fad that's just going to disappear? You think it's going to expand? You think it's just going to remain a sort of a boutique subsector of spine surgery? What do you think is going to happen?
That's a very interesting question. And I would like to say that I think it's going to continue to expand. If you look at the tools that are available now, the techniques that we have in front of us, even doing complex osteotomies, to be able to do that in a minimally invasive or mini-open standpoint, I think that the sky's the limit. This will continue to advance. However, as we've seen in the MIS world, there's still fear of adoption of these techniques. So I don't think this is going to become the way to do this. But I think as we start seeing this or the next generation, maybe the generation of surgeons after that, this may become the predominant way of treating these, even complex deformities.
Great. Well, thank you for watching and listening. Ask the experts.